McGraw-Hill Ascent Audio presents The Healthcare Mandate: How to Leverage Disruptive Innovation to Heal America's Biggest Industry by Nicholas J. Webb, narrated by Emmanuel Chumaceiro. Publisher's note: this audiobook contains references to visuals present in the print and ebook editions of the book. Preface. During my 40 years in the healthcare industry, I've enjoyed meeting a cross-section of the world's healthcare thought leaders. While some have been well-known media and industry personalities, others have been quiet, unassuming people dedicated to making a difference, one patient at a time. Perhaps the most profound connection I ever made was with Dr. Manly Michelson. He was not a Nobel Prize laureate, world-renowned surgeon, or even academic royalty. To me, he was much more impressive than all of those. Dr. Michelson was an old-fashioned family doctor. He served the community of Bellevue, Iowa, a town of over just 2,000 souls, primarily farmers and everyday hard-working families, nestled on the banks of the Mississippi River. Dr. Michelson, known to friends simply as Doc, and who died in 2008 at the age of 77, understood the incredible importance of the relationship between the doctor and the patient. He took his role very seriously. He loved his patients, and they loved him. This love was based on his incredible commitment to his patients, not merely as a physician, but, more importantly, as a compassionate and loving human being. In those days, before specialized medicine, Dr. Michelson offered a wide range of medical procedures. He set and cast fractured bones, ran his own X-ray machine, delivered babies, repaired lacerations, and even performed tonsillectomies at the old Bellevue Hospital. He routinely made house calls to families in the Bellevue area, and he especially loved caring for children, always arriving equipped with a variety of toys and techniques to make his young constituents laugh. After he retired, with great reluctance because his health was failing, he gave me 2 of his doctor's bags. Familiar to anyone of a certain age who remembers when doctors made house calls, these battered black leather bags have become among my most prized possessions, not because they're of particular value, but because of what they represent: a time and place when the doctor-patient relationship was close, and primary care physicians, although the term hadn't yet been invented, were much more than technicians who diagnosed and treated disease. The lessons I learned from Dr. Michelson were revitalized when I met Dr. Ray Power of Dublin, Ireland. I was speaking at a large conference in Dublin, and at the end of my presentation, Dr. Power enthusiastically greeted me. I was startled by the first thing that he said to me: "It's all about the patient." He went on to tell me that in his career he always felt honored to be in service of patients. As I got to know him, almost every discussion was about his passion to change the conversation about healthcare and how we needed to refocus on the doctor-patient relationship. I also learned from Dr. Power that healthcare is about both science and art, and how the beautiful art demonstrated by caring physicians requires the support of a healthcare industry that gets us back to compassionate care, fueled by, but not led by, both technology and economics. While the business of healthcare must still be all about the patient, or as I redefine patient in this book, the constituent, I do not advocate returning to the days of family doctors making house calls. Those days are gone. This book is about leaping forward to a new era of doctor-patient closeness in which the doctor and his or her constituents are in constant digital communication. This growing connectivity is just one of the major trends, the big shift that's changing healthcare. For some, these new developments may seem impractical, far-fetched, or even suggestive of Big Brother. But I believe that if we can forge a bond between high technology and high touch that comes from a human-first approach, These new technologies can be managed to significantly improve the quality of clinical care while allowing for a newly energized focus on compassion and human connection. Introduction. In this time of crisis in the healthcare industry, you and every other person in a position of leadership need sharp analysis to identify problems and powerful new ideas to implement change. You need a fresh perspective on how we got ourselves into our current situation, explanations of future trends, and specific action plans to get your organization on track to meet the demands of a changing marketplace. The language we use to talk about the problems facing the healthcare industry and the solutions to these problems is important. In the healthcare mandate, you'll note I use the term marketplace in the context of the healthcare industry. I'll also talk about customer experience, another term that's increasingly being applied to the healthcare industry. You'll hear about the big shift, which can either destroy your organization or act as a lever to propel you into the future. You'll hear very little talk about patients, but much about constituents, a broader term that more accurately reflects your changing relationship to the people you serve. I'll discuss organizational innovation and how any organization in any industry needs to innovate or perish, including healthcare companies. We'll explore the power of technological progress and how digital communications can reshape the doctor-patient relationship. We all know about the sudden explosion of lifestyle diseases, conditions such as obesity, diabetes, and heart disease that are caused, or at least intensified, by the personal choices made by your constituents. How, we ask, can we effectively treat those whose behavior puts them at risk for getting the same disease all over again? The truth is that we're discovering we can't, and throwing money at the problem isn't the answer. This book begins the conversation about your constituents taking personal responsibility for their own health care, not responsibility for disease over which they have no control, such as hereditary conditions, but responsibility for choices they make that adversely impact their health, thereby raising the cost of health care for everyone. None of the ideas offered in this book are far-fetched or imaginary. All of them are operational in some form right now. This is a book for today, not some vague time in the future. For example, I talk about connecting every constituent with his or her primary care physician by the use of a digital device to send real-time health data to the physician, who will be alerted if the data suggests a health problem. Impossible? Hardly. At this very moment, millions of people are using wearable health monitoring devices, and implantables are already in use, not only in pets, but in humans. We explore the idea of penalizing constituents who consistently make poor health choices. Crazy? We already do it. If you choose to smoke cigarettes, in many states you will pay more for health and life insurance, and high taxes on cigarettes are designed in part to discourage smoking. We discussed the question of the personal health data of your constituents. Why would your constituents possibly agree to allow the real-time streaming of their data if they thought it would be sold at a profit to another company? There are people who are working on this problem, and with the help of blockchain technology, your constituents have the ability, right now, today, to assert their ownership of their own personal data. The big shift in healthcare is happening now. This book will help you understand it and leverage its enormous power and potential for the benefit of your constituents and your organization. The future can be either very grim or very bright. You already know which path you want to take, and the healthcare mandate can help you on your journey. Ready? Let's get started. Chapter 1. Change is happening now. Let's journey into the not-too-distant future and meet Roberta, At age 70, Roberta is in very good health. She's happy with her healthcare providers. This group includes not only her primary care physician, but a set of stakeholders comprising her employer. Yes, she's still working. Health insurer, the local hospital, medical data managers, pharmaceutical companies, even government regulators, anyone with an interest in her wellness. She's so happy with them, she doesn't think about them very much. This is because she doesn't have to. Digitally connected to her, they hover out of sight, like guardian angels watching over her, day and night. If they detect a health problem on the horizon, a change in her blood chemistry, or a variation in the pressure in her eye, her primary care provider sends her a message. If necessary, her primary care provider asks her to come to the clinic for an examination or consultation. Roberta's Constituent Healthcare Operating System, CHOS, which we'll learn more about in the sections ahead, is designed to meet the twin goals of anticipation and prevention. The CHOS's Central Processing Module, which could be located anywhere, captures and stores the steady stream of Roberta's biomedical data, along with her genomic profile, environmental trends, and new medical technologies and discoveries. It cleans the raw data before turning it into actionable information. When necessary, the Constituent Healthcare Operating System responds with a call for appropriate intervention. This process allows the CHOS to anticipate emerging health problems and prevent them from blossoming into full-fledged disease. Roberta lives in a culture in which wellness is rewarded. This is not to say that infectious diseases and accidents are ignored. Western medicine has long excelled at defeating viruses and fixing physical damage. But in the system that Roberta is happy to be a part of, the focus is on anticipating and preventing not only infectious diseases, but the deadly lifestyle disease, obesity, diabetes, heart disease, addiction, which, when she was younger, afflicted many other people. As Roberta goes about her daily life, sometimes she reflects on her current state of health and how it has dramatically improved since she was a young woman. Back then, she was overweight and smoked cigarettes. She had a primary care physician, but he did what most well-meaning doctors do, which was to provide the usual physical exams, note any worrisome personal habits, and give Roberta a pep talk about reducing her weight and quitting smoking. Then, one day, Roberta started to have abdominal pain. It was accompanied by a feeling of nervousness, heart palpitations, headaches, and elevated blood pressure. She went to her doctor, who ran the usual blood and urine tests but found nothing unusual. He gave her a blood pressure medication and sent her home. The symptoms persisted, and soon anxiety and sleeplessness were added to the list. Roberta went back to her doctor, and this time the blood and urine tests included a measurement of the level of her adrenal hormones, which can detect a functional tumor. Roberta was required to provide a 24-hour urine sample, which meant she had to collect her urine for an entire day, so it could be used for laboratory testing. Her doctor used a dexamethasone suppression test to check her cortisol levels. They were found to be elevated. More tests followed. First a CAT scan, and then a scan designed to detect the presence of meta-iodobenzylguanidine, which would and did indicate an adrenal tumor. Then came the staging, the process by which doctors determined the exact location of the tumor, if it were cancerous, if or where the tumor had spread, and whether it was affecting other parts of the body. Next came the surgery. The tumor was larger than 5 centimeters, so a large incision in her back was needed. Roberta was hospitalized for 6 days. Once she was sent home, she was told not to lift heavy objects for 6 weeks. The cost for her adrenal gland surgery was $25,000, which was a middling price. Neither the cheapest nor the most expensive. She made a full recovery. By all accounts, her treatment had been a success, at least by the definition at the time. Costly, yes, but what else could you do? Those big machines were expensive, and the patient was entitled to treatment to fix her problem, for which her health care plan was obliged to pay. By a very slight degree, Roberta's surgery for her adrenal gland tumor contributed to the upward price pressure on healthcare insurance in America. Little by little, dollar by dollar, healthcare costs continued to rise, but with no better outcomes. At the time, and despite individual success stories like Roberta's, analysts, doctors, insurers, and ordinary citizens were becoming convinced that our healthcare system was not serving patients well. It was a time when a Harris poll revealed that only 16% of U.S. consumers believed health insurers put patients over profits, and only 9% thought pharmaceutical and biotechnology companies did. "We are in the midst of a healthcare maelstrom," said Wendy Solomon, Vice President of Reputation Management and Public Affairs at Nielsen. "Consumers see no safe port, no place where their interests are truly protected, and that lack of consumer trust is reflected in the reputational risk we see across the U.S. healthcare landscape." To healthcare constituents like Roberta, the flaws were obvious. Costs were sky high and outcomes often poor, but no one had any clear answers. The patients blamed the healthcare providers and insurers, who blamed the government, who blamed the patients. It was like a house on fire, with everybody arguing about how to put it out, and no fire department in sight. Fast forward to Roberta at age 70. Times have changed. The strategy taken by Roberta and her healthcare providers has been reinvented. They had learned, and were acting upon, two key lessons. Treating an emerging disease is better than battling it when it's full-blown. And keeping a person healthy is the best way to reduce that person's rate of disease. It costs much less to prevent disease than to treat it. And not only in direct payments to the healthcare provider, but in lost productivity when the patient is out sick. Now the healthcare emphasis is on anticipation and prevention. Treatment is much lower on the list, and because it comes much earlier in the disease cycle, it's shorter, easier, and cheaper than in years past. Now, Roberta's hormone levels are closely monitored by the central module of her constituent healthcare operating system. She's grateful that today, if hypothetically her CHOS module were to detect a slight but persistent elevation in any one of her key hormones, including cortisol, androgens, and aldosterone, the module would send a notice to her primary care physician while simultaneously searching for other anomalies such as high blood pressure and low blood potassium. If found, they would be added to the report. All of this would happen without Roberta having to do anything. She could live her life knowing that at the very first symptoms, of which she might not even be aware, her medical team would be alerted. People dodged their doctors. In the old days, the relationship between Roberta and her healthcare providers was dependent on the patient's motivation to self-report disease symptoms. The patient first had to notice a problem and then actively seek treatment. If the patient failed at either action, the disease or injury could intensify unchecked. The way the system worked was this. A person such as Roberta, or anyone else, would go about her daily affairs with no contact with healthcare providers. Then, if Roberta felt sick or noticed something unusual, such as abdominal pain, she would contact her doctor. If the doctor deemed the problem to be an emergency, she might see her doctor quickly, perhaps even the same day. If it was not considered to be an emergency, then she might see her doctor in weeks. Specialists were often booked months in advance. Eventually, the problem would be diagnosed. By this time, her condition would have advanced so that she required surgery, and Roberta would receive the treatment she needed. Even within this imperfect system, by virtue of being proactive, Roberta was the ideal patient. She was her own health monitor, and she responded when she sensed or saw something amiss. This was about as good as it got. True, it might happen that Roberta could go for a routine checkup while showing no symptoms, be tested, and get flagged for disease. This approach has worked with mammograms and colon cancer tests, which people seem to accept. But those are just two diseases, and the use of such tests by patients is not 100%. This method also requires that patients get routine checkups, even when they feel fine. Most people, especially men, don't get regular checkups. Millions of people are not ideal patients. Unlike Roberta, they might be insensitive to the signals their body sends them, fail to recognize a warning sign, or be unwilling to call their doctor. They might wish the problem would go away if they ignored it. They may think they can battle through the problem without professional care. Perhaps the biggest reason why people put off calling their doctor is because they're afraid of the cost. In a national poll of more than 1,300 American adults, 44% of respondents said they didn't go to a doctor when they were sick or injured in the previous year because of concerns about cost, and 40% said they skipped a recommended medical test or treatment for the same reason. The poll conducted by NORC at the University of Chicago and the West Health Institute revealed insights into how the costs of healthcare affected the medical decisions made by respondents. 30% of respondents said over the previous year they had to choose between paying for medical bills and paying for basic necessities like food, heating, or housing. Many said they were not only delaying seeing their doctor, but also going without recommended care, such as tests and treatments. Statistically, men are more averse to seeing the doctor than women. Over a 2-year period, men are half as likely as women to go to the doctor, according to a survey data collected by the U.S. Centers for Disease Control and Prevention. Men are also more than 3 times as likely to report going more than 5 years without a visit to a doctor, and more than twice as likely to say that during their adult life they've never had contact with a doctor or health professional. This massive level of doctor avoidance is not proving to be a very good strategy. Men tend to die earlier than women and are more likely than women to die from 8 out of the top 10 causes of death in the United States. While researchers believe several factors are involved in men's shorter lifespans, a major reason is that men don't go to the doctor as often as women do. Why not? A survey commissioned by the Orlando Health Hospital System provided insights into why many men avoid their doctor. According to the survey results, claims that they are too busy, discomfort with certain physical exams such as prostate checks, and false pride keep them out of the doctor's office. On top of that, many men see asking for help as a sign of weakness. They want to be self-sufficient tough guys. As Orlando Health's Jamin Brambot, MD, wrote, "Women are much more proactive about their health than men. This may sound harsh, but this complacency is killing us. Far too many men die or experience compromised quality of life because of preventable diseases." He then drew an analogy that many men can understand. Our bodies are a lot like our cars. We'll take the time to do preventative maintenance on our cars, getting tune-ups and oil changes, but we often don't take the same care of our bodies. Motor vehicles self-report damaged components. Indeed, the comparison to automobiles is worth making. Since their invention over a century ago, automobiles have been equipped with rudimentary mechanical sensors that provide information about the car while in operation, such as the fuel gauge and oil pressure indicator. For example, when the oil pressure gets too low, the little red light on the dashboard begins blinking, alerting the driver to the problem. The capability of motor vehicles to report on the status of key systems has steadily progressed, and with the advent of digital communications in the 1980s, it took a big leap forward. As we enter the third decade of the 21st century, Motor vehicles of all types are becoming increasingly able to diagnose their own mechanical problems and report these to the dealership, and even to schedule repairs and order new parts, all without the driver's involvement. Electric automaker Tesla touts its ability to offer cars that virtually maintain themselves using the Internet of Things, IoT. Each Tesla vehicle, its service center, and the factory are interconnected in real time, allowing technicians and engineers to work together to identify and resolve issues as they occur. Within hours, says the company's website, we can make updates across our entire customer fleet. We are also developing new ways for your Tesla to self-improve. The result is a car that is constantly evolving and improving, allowing you to stay out of the shop and on the road. With the car's remote diagnostics, the company says that 90% of the time it can remotely diagnose an issue and what is needed to repair it. The car's software can be updated by the factory remotely, and if there's a problem, a feature Tesla calls Smart Alerts can communicate to the owner what the car needs and walk the owner through a simple fix or connect the owner to the company's service team. Many vehicles are now capable of performing self-diagnostics and reporting the results. Cadillac offers the OnStar system, which among other features checks the vehicle's engine, transmission, anti-lock brakes, and other key systems to assure the owner that the car is in proper running condition. With OnStar's diagnostic alerts, the owner can receive a monthly diagnostic report, but OnStar is also able to detect future problems. A proactive alert is sent to the OnStar member when data from the vehicle's systems predicts potential issues with key vehicle components, including the battery, fuel pump, fuel pressure sensor, and starter motor. In 2017, Italian supercar manufacturer Lamborghini announced it had created the world's first self-healing sports car. The Terzo Millennio concept car, which translates to third millennium in Italian, is equipped with sensors that conduct checks to detect any damage, and then the car can repair itself by filling any crack with nanotubes to prevent the crack from spreading. Created in collaboration with researchers from the Massachusetts Institute of Technology, these body panels will use electricity-storing carbon nanotubes sandwiched between two laminates of carbon fiber. If sensors detect damage to the carbon fiber, microchannels can generate heat to seal cracks and mitigate the risk of any further damage. In their paper, An Integrated Self-Diagnosis System for an Autonomous Vehicle Based on an IoT Gateway and Deep Learning, Korean researchers Yina Jung and others describe how the cars of the future will be able to diagnose more faults and conditions than ever before, a feature of car ownership dramatically influenced by the IoT. The authors propose that using information gathered from the sensors within the autonomous vehicle will allow it to diagnose itself and assess the influence between parts by using deep learning, and then the vehicle would inform the driver of the result. The integrated self-diagnosis system would consist of 3 modules. 1. The first in-vehicle gateway module collects the data from the in-vehicle sensors. This data comes from sources including component sensors, the black box, and the radar units while driving. The data control center transfers the data collected through each controller area network, FlexRay, and through the media-oriented systems transport protocol to the onboard diagnostics or actuators. 2. On the basis of the data collected from the in-vehicle sensors, the optimized deep learning module creates the training data set and evaluates the risk of the malfunction of monitored components. It also diagnoses the status of the vehicle's total condition. 3. The third data processing module has an edge computing-based self-diagnosis service to improve the self-diagnosis speed and reduce the system overhead, while a V2X-based accident notification service informs adjacent vehicles and infrastructures of the self-diagnosis result analyzed by the onboard diagnostics. This last feature allows the vehicle, which may be operating on the street or highway, to notify nearby vehicles of its potential mechanical problem, thereby reducing the risk of an accident. What works today in cars will soon work with people. Imagine getting into a crowded elevator. As the doors close, you notice that the man next to you is coughing and seems short of breath. Then, suddenly, you receive a digital warning relayed to you from the man's biomonitor that says, based on his detectable...
Sample complete. Ready to continue?